Hi everyone, this is Dr. Massengale. I'm going to create a quick video going over chapter 7 and taking a look at depressive disorders. Families and communities play a heavy toll when a disorder involving an individual's mood is not recognized and treated. For so many individuals who suffer from these disorders, problems with family relations and support systems are common, as well as the potential for suicide. In children, adolescents, and adults who suffer from a depressive disorder, lack of desire to function can lead to employment and school difficulties as well. These feelings of depressive mood can have devastating effects on the client and their family. So it's imperative to promptly recognize what would be considered a normal depressive reaction and what constitutes a depressive disorder in children, adolescents, and adults. No single medicine, therapy, or treatment holds the key to success with these disorders. So we need to be open-minded about all options in order to best assist individuals suffering from these disorders. So the most prominent characteristics shared is the cognitive, somatic, and emotional changes reflecting feelings of extreme sadness or irritability. The duration, timing, and presumed cause of the illness differentiates the disorders. The effects experienced can be so severe that they affect an individual's ability to function. In terms of onset of the disorder, age is a significant variable that can denote the course and symptomology of the illness, particularly anxiety and suicide risk. So this stresses the importance of diagnosing this disorder as early in the course as possible. When the mental health practitioner is completing the diagnostic assessment of an individual who suffers from a mood disorder, depression is a common symptom that overlaps symptomology with many other disorders. Remember, in the last video looking at bipolar, there can be depressive episodes, so it's harder to differentiate in order to come up with our diagnosis. So when clients report feelings of depression, a lack of clarity and problems in semantics and defining what is actually being experienced in terms of magnitude and frequency can be problematic. So feelings of depression are frequently overstated or understated. They're influenced by the definition and normalcy standards set within an individual's unique social and environmental context as well. So for many, depression can mean feeling sad, blue, or down in the dumps. For others, it clearly established criteria with consistent patterns, signs, and symptoms of a mood disorder. Some forms of depression, also referred to as dysphoric mood, overlap with other mental health conditions. So understanding the depressive disorders is the first step to becoming aware of the different types of disorders that are listed within the DSM-5. One reason this lack of proper assessment of symptoms is so problematic is the symptoms that clients are self-reporting. So much of what we know about a client suffering from depression or any other mental health condition for that matter comes from self-report. How clients interpret and report their symptoms of being experienced can be easily misleading because feelings of depression can easily be understated again. The client's subjective experience is being reported, so this interpretation reflects the definition and standards of normalcy within their social, cultural, and environmental context. Taking into account the influence of life factors on self-report is essential. So reported symptoms are always influenced by many factors, including current and past relationship problems, irritability with the situation, and work-related conflicts. All diagnostic interpretations must be sensitive to the influence of cultural and stress-related environmental and social factors. Some ethnic minority groups are exposed to tremendous contextual stressors that can affect the presentation of depression, including poverty, poor and rundown neighborhoods, acculturation, and loss associated with, quote, never going home again. The social context of immigrants needs to be assessed as well, as their depressive symptoms may stem from a conflict of values from their country of origin compared to the American customs and values, problems with speaking the English language, parenting stresses, conflict between children and parents' beliefs and customs. So therefore, in assessing depression, the practitioner must consider not only what symptoms a client reports, but also the cultural influences and complexities of the client's cultural identity. We must also be willing to consider how gender, socioeconomic status, social class, geography, race, religion, And politics may influence that adjustment and how important these factors are in accurately assessing depression. So there are two types of serious depression. The first is often referred to as endogenous or melancholic depression. In this type, symptoms of depressed mood are related directly to an internal biological factor, such as neurotransmitter dysfunction. So people who experience this type of depression often report a loss of pleasure in almost all of their usual activities and symptoms of severe anhedonia, hopelessness, and inappropriate guilt. Suicidal symptoms may become a concern in this as well. In the second type of serious depression, there's a primary relationship between personal character-related factors or neurotic responses and precipitating events. This form of exogenous or environmental depression is sometimes referred to as reactive depression. So the signs and symptoms manifested relate directly to life stressors or other psychosocial factors such as divorce, unemployment, injury. Depressive factors such as a decreased psychomotor speed, attention, and verbal memory may also be directly related to the reactive life circumstances such as unemployment, even when the depressive condition is in remission. So whether the depression is endogenous, so related to internal causes, or exogenous, related to external or environmental causes, or a combination of both of those, the first clinical feature usually presented in major depression is dysphoria, or a disturbance in mood, or anhedonia, which is a loss of pleasure or interest in normally enjoyable activities. Besides dysphoria and anhedonia, depressed individuals feel a wide range of complaints that include feelings of guilt, inability to concentrate, feelings of worthlessness, somatic complaints, feelings of anxiety, chronic fatigue, and usually a loss of sexual desire. So there are several depressive disorders listed in the DSM. The first one listed is rapid mood dysregulation disorder, or DMDD. So this disorder has 11 specific criteria that must be met. The core feature is irritability that is persistent for at least a year and maintains a severe and continuous course that is not related to a developmental phase. So remember, this one is for children and adolescents. The behaviors are not consistent with a precipitating event and involve either verbal or behavioral manifestations toward people or property, so outbursts. These temper outbursts must be continuous, occurring in at least 3 or more times over a 7-day period. Major depressive disorder, or MDD. So there are 9 primary symptoms, and the individual must have at least 5 of them, so 5 out of the 9. In addition to these symptoms, they must all occur in the same 2-week period, and the individual who suffers from major depressive episode must either have a depressed mood or a loss of interest in daily activities consistently for that 2-week period. There's persistent depressive disorder, or what used to be called dysthymia, so it's also known as PDD. This is a milder yet more chronic form of the disorder, requiring a 2-year history of a depressed mood. The individual suffering from this disorder is not without the symptoms for more than 2 months at a time over that 2-year period. This disorder is considered less severe than major depressive disorder, but it's constant for 2 years, during that which the individual experiences some symptoms related to the disorder almost every day. There's premenstrual dysphoric disorder, or PMDD. This is a new condition to the DSM-5, and it occurs in women who have severe depressive symptoms, irritability, and tension that occur before menstruation. And then we also have the substance medication depressive disorders, medical condition related disorders, other specified and unspecified depressive disorders. So again, I've posted videos on the announcements page that goes into more detail about each of these. So take a minute to watch those videos so that you're more familiar with each of these disorders. Okay, so now we're going to look at the case scenario of Joey. So if you haven't yet, go ahead and pause this video and read the case scenario on pages 260 to 262. And then we'll walk through the symptoms and our diagnosis and treatment. Okay. All right. So demographics, we know that Joey is a 12-year-old male. He's stated as being overweight. We're getting information from mother, sister, and teachers. And we know that he is in inpatient care after his arrest. Presenting problems, there's concerns. The main concerns focus on temper outbursts, unpredictable verbal and physical responsiveness, concern over returning home. We know that there's family relationships are strained. Environmental aspects, say that parents are divorced, the father does not engage much because he doesn't feel like he can control Joey. Joey says he doesn't have friends and he hates his family. So then looking at symptoms, we have angry outbursts, stating that he's difficult to manage, always negative, having temper tantrums. There's a note that he struggles in school, breaking toys or other people's property, does not want to be around people, states that he hears what other people are saying, but he chooses not to respond, states that he's sad and feels empty, his anger is constant. It's been noted that there's an increase in appetite and weight gain, increases in sleep, difficulties, tired all the time, concentration difficulties, low self-esteem, some passive suicidality, saying that he just wished he was dead. And then there have been legal or issues with an arrest for simple assault. So again, so some clinicians and practitioners might immediately jump to disorders that we talked about in chapter 11, looking at behavioral impulse control disruptive disorders. So they may immediately jump to diagnoses of ODD, IED, or conduct disorder. So, which would make sense because look at these symptoms. They line up pretty well with disruptive impulse control and conduct disorder disorders listed in the DSM. The angry outbursts, the temper tantrum, breaking things, some defiance, and the arrest. But if we just look at those, we miss other symptoms. So we still have this kind of this isolation, not wanting to be around others, feeling sad and empty, increases in appetite and weight gain, sleep difficulties, concentration difficulties, low self-esteem, suicidality that are disruptive impulse control conduct disorders do not cover. So let's take another look. So in our chart here, we have DMDD, MDD, PDD for depressive disorders. We'll also take a look at those disruptive impulse control and conduct disorders. And then also we need to take a look at our bipolar related disorders. So with our bipolar related disorders, there can be symptoms of depression. There must be manic or hypomanic episodes. But it doesn't really cover our irritable mood and our anger outbursts. So this one doesn't feel like a good fit to look at for Joey. So moving on, kind of looking at our disruptive impulse control and conduct, it looks like it's covering our irritable mood and our angry outburst, but it's not covering any of the depressive symptoms that we may be seeing in manic or hypomanic episodes if we see those. So if we look at DMDD, we see that it covers our irritable mood or anger outburst. But again, just like our disruptive impulse control and conduct disorder, it's not really covering, DMDD doesn't really cover our depressive symptoms or any manic or hypomanic. So remember, DMDD cannot coexist with oppositional defiant disorder, intermittent explosive disorder. So individuals whose symptoms meet criteria for both disruptive mood dysregulation disorder and disruptive impulse control and conduct disorder should be given the diagnosis of DMDD. Okay, so that takes away our impulse control disorders. So now comparing DMDD to other depressive disorders to see if we can find one single disorder that covers all of our symptoms. So both MDD and PDD would cover our depressive symptoms, and it would cover our irritable mood. Remember that for children and adolescents, sometimes depression presents as irritability instead of sadness. Okay, so that covers those two. However, if there were symptoms of manic or hypomanic episodes, our depressive disorders would not cover that. and MDD and PDD don't cover our anger outbursts. So it seems like right now there is no one diagnosis that covers all the symptoms that we're seeing. So my diagnostic impression is looking at these symptoms. So maybe DMDD for our irritable mood and our anger outbursts. That seems to fit. But then I'm also the book doesn't do this, but I'm also looking at a PDD, a persistent depressive disorder, that would cover our depressive symptoms and episodes and some of our irritable mood as well. So I don't feel like there's one diagnosis that could cover everything. So for me personally, and again, this differs from the book, I'm looking at the primary diagnosis being disruptive mood dysregulation disorder, which is also the reason for the visit. Again, there are Z codes, so parent-child relation problems, academic or educational problems, problems related to other legal circumstances. But then I'm also adding a diagnosis of persistent depressive disorder to cover the depressive symptoms that we're seeing. So for PDD, there are specifiers that need to be added. So it would be early onset, since we're seeing these symptoms in his childhood and adolescence. I would consider it with pure dysthymic syndrome, meaning that he hasn't met the full diagnosis of a manic, or not manic, excuse me, of major depression. I would consider the symptoms mild at this point in time. So looking at Joey's treatment, remember, you need to make sure that you're looking at the presenting problem and considering treatment strategy, looking at treatment options, so the setting, the participants, the types of therapy. Again, is this inpatient or outpatient? Is it just the client? Does the family need to be involved? Do teachers need to be involved? What types of therapy? Individual, group, family, psychoeducation? And then remember that your theory, your aligning counseling theory, will help you determine your goals of treatment, your intervention, and the roles that both you and your client play. So again, that was just a quick overview. Please let me know if you have any questions about depressive disorders. Thanks.